Again, welcome everybody to the Public Health PBRN monthly virtual meeting. Looks like we've got a good crowd of folks online with us today. And we've got a exciting agenda put together for you as usual. We'll start off with our monthly research in progress segment, and we are very pleased to have our colleagues from the great state of Colorado and our Colorado PBRN presenting work, some very interesting work that they've had underway today. We're especially grateful they're able to join us given everything that's happened, the public health emergency that's been playing out there in the Front Range, and our hearts go out to all of you guys out there. We hope that everything is going well and you've got recovery underway. And again, we're glad that you've been able to keep this on your schedule for today. The topic that you see here, implementing a minimum package of public health services, some findings from Colorado. Obviously, this is a topic of pretty profound interest these days, in part based on the Institute of Medicine recommendation from last year to develop such a package like this on a national level, and work that's underway in several states to inform these decisions and to inform the parallel state level policy decision making that's playing out here. So it's great to see some very timely, very informative work coming out of our Colorado PBRN. And so I will turn it over to Sarah Lamp, I believe, and welcome to the show.
Thanks, Glenn, and thank you guys for actually putting us in here. So just quickly, we were rolling out and starting to really move forward in our dissemination plan for this project, and I emailed Lizeth and said, you know, we'd love to get in on one of these monthly calls if there's a possibility, thinking, you know, maybe like January, February next year. And then she emailed me promptly the next day and said, well, how about September? And I was like, okay. So
we are just that quick.
Yeah, just amazing. I mean, the turnaround time is spectacular. So I want to just make sure we give a great debt of gratitude to you all for fitting us in to be able to present some really preliminary findings, but really get an understanding of where we are and looking at our data and information that we have thus far. And Lizeth, are you guys going to control the slides, correct?
I can do it either way. If you're able to, the bottom ribbon bar, there's an arrow up and down, and that's how you control them.
Might be easier for you. I am not seeing, there you go. Okay.
That's perfectly fine.
Okay, I'll just say slide when it's time. So, and I also want to I have two colleagues who are also on the phone. I'm going to do the brunt of the presentation, but when it comes to question and answers, I have Adam Atherley and Julie Marshall. Both Adam's a PI on this project and Julie's a co-PI on this project from our Colorado School of Public Health. So they'll be able to answer some questions and really start thinking through some other items at the end of the presentation. And I also have to put a little caveat out there. We did this presentation to our local public health. We are currently in Breckenridge for our annual conference for our state public health Association. So I tweaked the presentation from yesterday for today, but there may be some items that I'm going to skip over a little bit because I failed to take the slides out or to change them. So I apologize for that. But a little bit of what we're going to go through today, I'm going to do a little summary of our project, talk through our measurement development, and then go through some preliminary data. And then would love to hear some questions, input, thoughts on future analysis and dissemination with the large quantity of data that we do have. So next slide. So a little bit of background. Back in 2008, and I'm sure you all have heard this from us before, but just as, again, a background, 2008 we passed the Public Health Act, which really restructured our local governmental public health system across the state from a two-tiered nursing services organized health department to every jurisdiction had a local public health agency with local boards of health. And it established some CHA and SHIP requirements within the law, as well as some qualification public health directors, funding formulas, and very importantly for this project, determined what the core public health services are, that there should be core public health services in the state, which is, the term we use here as core services is on the national stage now discussed as the minimum package of public health services. The next slide. So the core services that were promulgated into rule in October 2011 are sevenfold. There are assessment, planning, and communication, vital records and statistics, communicable disease prevention, investigation, and control, prevention and population health promotion, emergency preparedness and response, environmental health, and administration and governance. And I will say that we, when the process came to determine what the core services would be, there was a lot of discussion about where we would land within and across the core services. Do we just say you should do the 10 essential services and allow the agencies to have a lot of freedom in what they determine those are within it, or do we need to really determine and say every little thing that the agencies should do? And we had agencies, our local agencies, on both ends of that spectrum, where we had some agencies who said, if you don't tell me I need to provide immunizations, then we're not going to be able to provide immunizations. Our county commissioners, our Board of Health is going to tell us we can't. And then others on the other side who are like, I don't want the state health department to determine that I have to do immunization. So, we landed at these 7 services, and then within the rule there are details within each of them that kind of determines what really makes up each of those services. Next slide. So our aims within this project were to examine the effects of the regulation on the adoption, or what was in the law. It said you could either adopt or assure core services by the local public health agencies. And then the second one is to examine what structural factors affected the actual adoption of those core services. And then the final one was to examine what changes in health outcome might be related to those adoption of core services. Now, with this last one, we are fully aware that we would likely not see changes in health outcomes, but it still was, well, one of it was a requirement of the grant, but also it's something that we are kind of setting up within the core service areas and the measures that we determined to be able to say in the future when those health outcomes do change, that we can actually create those correlations. Next slide. So the study design is a longitudinal pre-post assessment of the delivery. Our pre was a baseline, which was actually done prior to even writing the grant, which was completed in August of 2011. Obviously, the intervention is the rule, and the post is the annual report, which we completed this year. And most of the data that we'll be presenting today will be based on that post, but some of it will be looking at the pre and the post. Next slide. So the baseline review was what we determined as a pre-measure. Now, I will say that the baseline review itself and the instrument that was developed for it were not actually considered or thought of as aspects of research, but was really meant to gather information for the rulemaking process to ensure that we did not have legislators who were saying, this is an unfunded mandate, you can't do it. We were really getting an understanding of what our public health agencies do, how they do it, to ensure that we could come to the legislature with a core service rule and say, yes, and the large majority of our agencies are already doing this work in some way, shape, or fashion. Next slide. So it was conducted in the spring and summer of 2011, and we were able to have all 54 of our local public health agencies participate in this portion. It was quite an extensive tool. It included a 3 to 4 hour interview with directors and staff members and some Board of Health members to really talk us through how they filled in the instrument that we gave them and to really get a better and more thorough understanding of how they do what they do. And then we reviewed the instrument and resubmitted it to them for any gaps. And then, unfortunately, with that part, we got a lot of places where we had gaps. We asked people to fill in, they didn't, because they considered the interview to be kind of the end of the session. So we do have some gaps in the pre-data, but not enough. And actually, in very particular areas that when you see how we went through the decision-making process for the post, we were able to kind of those measures. Next slide. So the tool was made based on existing and validated tools for as a starting point for the development of the baseline reviews, but it was expanded quite extensively by conversations with people in our state health department and our local public health agencies. Next slide. So we started with this concept of, we could use a nature profile to let us know what people do, but it really gives us just a very cursory understanding of what people do. So, you look at nutrition and a nature profile, and our local health agencies could just be giving out pamphlets at the door if someone says that they want more information about good nutrition, versus those who are doing policy work with their schools or doing actually, making gardens in their communities or things like that that actually required a little bit more amplified work within our local agencies. Next slide. So this is an example of what came from the baseline, and you'll see that if you look at nutrition promotion, this is one of the service areas that we looked at within chronic diseases, which is in prevention population health promotion. So you'll see that there are many layers that we looked at within our core services, but we were able to actually draw out even more detail. So not just do you do nutrition promotion, but what aspects of nutrition promotion do you actually engage in at this time. And what we saw from the baseline and why we wanted to repeat this is that we did see a large, our large majority of our agencies had education materials. That wasn't surprising. But then when it came to actually getting into much more detailed work within all of the services, not just nutrition is just the example I used here, we found that agencies who had more funding or more capacity were really getting much more of the detailed work done and more of the evidence-based practices done in the service areas. Next slide. So other data we gathered is we have this self-reported capacity measure, which is actually a Likert scale from 1 to 4 of what do you feel your capacity is at this time. And it really spells out that highest capacity means you have funding, you have staffing, you have political support, you're delivering it to all of your desired population, you're addressing health disparities, you have all the standards within that service met. This we actually had capacity measures of all of the particular areas within each of the core services. And we do hope in the future to be able to present a lot more information about this measure and what it really spells out to what it really looks like and what it really means, or if there's a better way or a way we need to think about actually defining capacity. The other data we have per core service is we had FTE and personnel, so how many people and how many FTE, funding, areas of improvement, and promising practices. Next slide. So we did follow-up data collection this year. Next slide. And we needed to be sure that we had a comparison to the baseline, but we also didn't want to ask the 1,700 measures. Yes, I said 1,700 measures that we asked from baseline. So next slide. We determined that we wanted our follow-up measures to be much more narrow and much easier to define. So we actually had a project advisory committee made up of practitioners from our local health departments, a few people on the phone currently, from national, from other practice-based research networks. We had a couple academics from our School of Public Health trying to fill in.
Get it to me once.
Trying to plan to understand the best measures that we wanted to keep from the baseline. So,
sorry, if you could you please put your speakers on mute during the presentation? Sorry, Sarah. Go ahead.
No, that's okay. Thank you, Lizette. So we used the Delphi process, which we actually modified from the MPROVE project. We had to give lots of kudos to Ken and Glenn and his staff for all the work that you did to determine your Delphi process, because we modified it and used a very similar process with our project advisory committee to determine the most important measures for us to use. So we took all of the world of knowledge of measures, and actually, if you go on to the next slide real quick, this kind of gives you an example of what we did. So within the area of environmental health, at baseline, we had a large monstrosity of a number of measures, 843. And from our just experience in our baseline interviews and knowing what people do, we took out quite a few. But we still had quite a few left. And so we asked our project advisory committee to look at the data that we had from the baseline and determine, which of the services are done. So what, where is the a lot of the work done in these services, and then the other item we asked them to look at to kind of rank is to rank which ones are actually the most important for the service itself. So, maybe not a lot of people are doing it, say for instance, work in the built environment and community planning, but it's an area where environmental health needs to see itself going. So to kind of rank on those two, and then we really were able to look at their rankings and determine the low-hanging fruit within the measures that were left. So we were really able to wean down even more, and then we went and we had conversations with local public health directors, environmental health directors, the state health department after that, and have conversations with experts to kind of weed out even more to come up with a final number of measures. So we did this within each of the core services, and it was a really helpful and useful process to really determine where we were going to focus our energy as far as the data collection in the post. Next slide. I wanted to recognize our project advisory committee because they really were essential in ensuring that we got the right measures. So I just want to put their names up there, particularly Beth and Golzar and Kim, who are part of our national network, who really have given us a national perspective to this local project that has given a lot of the other people on the project advisory committee a good lens to also look through outside of their local and state world. So thank you very much. Everybody should give them a round of applause. So our measure types were, again, very similar to the pre, but we have service delivery mostly in the area of availability of service delivery. The capacity measures again, and most of them were repeated exactly as they were in the pre, and some we actually parsed out even more to get an understanding of what are the particular areas within capacity that really drive that overall capacity feeling of where people's capacity are. We had some direct service measures, and we particularly spelled these ones separately as there are mixed political conversations happening across our state right now as to whether our local health departments, our local health agencies should be doing only population health services or if they should be doing direct services. And another aspect of that conversation is around the Affordable Care Act of what can be reimbursable, and the direct services are the items that are much more directly reimbursable versus those that population health services that aren't necessarily as easier for the payers to understand how to reimburse. We did FTE and staffing again, and then we did funding measures, and each of these were per core service as well. Next slide. Within each of for the entire instrument, we did pilot testing, which I have to say the pilot testing was one of the biggest benefits for us to do to get buy-in from our agencies to fully participate and actually fill in the information that we were asking them for in a very thorough and quality way. It was just an incredible way for us to get good local public health buy-in from the beginning because they were truly actively participating in determining what the measures should look like, if they're real within the work that they do, et cetera. We did retest reliability on a selection of the measures to be able to get an understanding of how reliable they are. We got 19 agencies to participate in the retest reliability, which is not ideal. It's not as many as we wanted, but we've had a lot of upheaval in our local public health agencies lately that left it so that the director, who was actually the one who participated in the first part of it, where it wasn't even there by the time we needed to do the retest. So in a 4-week time span, public health director was gone. So it not happened in several of our agencies, but it's a reality of something that we also have considered and thought about when we think about our data as well. And then we are doing validity since the it's really the 2012 nature profile that was released and done in 2013. we are looking at measures from that and are able to do some convergent and divergent validity to look at those measures. And luckily, some of the measures that we selected are also measures from the MPROVE project, so we are able to do some convergent and divergent validity on those measures that will also help with that national project. Next slide. So here is a very brief peek at what we have, and some of the information I'm going to tell you are not actually on these slides, but really what I want to talk about with this, with you all, is a little bit of some of the issues we've had with some of the analysis and data that we have, and talking through a little bit of that. So again, these are preliminary, and we're doing it in very small, some of the areas, not all of the core services. I've not included all of them knowing that we have limited time. And we're focusing more on funding and staffing, but some of the service delivery items. So next slide. So just to give you a general overall structure of our state, we have 54 local public health agencies. We have 51 reporting in this data. The 3 agencies who didn't participate aren't included in this data. Doesn't mean they didn't participate. They just turned in their information quite late to the point where we couldn't clean it and include it in what we have. I will also say that, and this is one of the issues that we're going to talk about a little bit later, some of our agencies had such a problem filling in financial and FTE data that they just refused to participate in that aspect of the project. So there are probably about 49 local public health agencies who actually participated in the funding and FTE part. And we have 58 satellite offices. That doesn't mean that every agency has a satellite office, but there are several agencies who operate many offices within their jurisdiction. Next slide. Our governance is a governance of the past. So before the Public Health Act, all the agencies were really governed by their county commissioners. Now that they are boards of health, essentially what has happened is our county commissioners have become the Board of Health. The majority of our boards of health are made up of elected officials, whatever, be that as it may. And so you'll see that a large majority are county commissioners. In fact, 30 of our agencies are still only county commissioner driven by their Board of Health. When you look at the expertise, we actually asked, how many of your local boards of health members have expertise in public health, environmental health, or other, and other was loosely defined to be any other health experience. So it came from an MD to an EMS or what have you. So when you're thinking about those who are really making the decisions of boards of health, or of the public health department and what they do, you're looking at large numbers of agencies who have absolutely no health or public health or environmental health experience whatsoever making those decisions. So this has ramifications in what our public health departments are really able to do and the arguments that they're able to have as far as providing more funding for health. You see a lot more of our boards of health who are more interested in roads than they are in the health of their population. So this is going to have ramifications for our practices across the state. Next slide. We did ask a question of where our agencies are with FAB, and this is actually 2010 and 2012. Sorry, the key keeps not being on the slide, and I'm not sure why. So the red is our 2012 data, and the orange is our 2011. So what we are seeing, which is great, is more people are actually know what FAB is, and I think if you look at the not planning to apply line, you see maybe one agency had made that determination in 2010, and we're looking at like 15 who said they're not planning on applying in 2012. In our minds, what that really means is that really those agencies at least know what FAB is and know right now that they are not doing it, as opposed to before where they were like, yeah, I don't know, or not even considering or discussing because I have no idea what it even is, which was happening in 2010. So that's a good thing to know, where our agencies are, as well as knowing that they at least know what FAB is now. So next slide. Okay, so I am going to go through a little bit of the core services and really talk about the FTE and funding, and I'm going to talk about some of the issues we've had. So the example I have here is communicable disease, FTE. And you'll see we have certain number of personnel, certain number of FTE. The interesting aspects are huge disparities between the max number of staff and the minimum number of staff dedicated to this. So we have actually several agencies who don't feel that they have any staff dedicated to communicable disease. Now we also have rural agencies who serve only 500 people. So in those areas, when they have one case of a communicable disease every year, really parsing out a person's time for those things is a little bit more difficult in those smaller agencies. But also if you look at the median, it really tells the story also that even across our state, we have minimum staffing dedicated to this particular core service, which a lot of people consider at the core of what public health does. The other aspect that I wanted to, no, you're fine, go on. You can go, okay. So the other aspect that we asked about was funding. So this is where our funding breaks out in communicable disease in the different areas we asked. A large majority of it coming from state and county sources. And in reality, that is the story across all of our core services. The diversification of our funding is pretty not there. And in reality, I think when I presented this at our public health meeting yesterday, I had people come up to me after the presentation who were like, that concerns me. That concerns me that if we're looking at county and state sources for a lot of our core services, we're actually putting ourselves in some trouble or potentially looking at areas of issue that we are needing to think about. Next slide. So here are some of the service delivery measures that we looked at. And I only have a few now because we are really trying to figure out how to best communicate this information. But you can see that we have each of these bars is kind of like a pie chart, if you want to think about it that way. And essentially you're looking at, whether it's done both at pre and post, so that's that red bar in there, or whether it was not done at pre and post, which is that orange bar that you see there. And then those who did it before and those who didn't and are doing it, not doing it anymore, and those who are doing it now and didn't do it before. So tobacco is an interesting story for us because we have our funding legislatively driven towards tobacco prevention that were taken away during the fiscal crisis. So we expected and are seeing a lot of variation in what agencies are actually able to do before in 2010 when they didn't have as much funding as they do now, and what they're doing now as the funding is coming back. So the funding came back in the middle of 2012. So we're still seeing some transition, and we're hoping, if we were to look at this measure again in a year or two, we would probably see even more transition into more work being done in tobacco so long as the funding stays where it is. Next slide. So nutrition is a little bit of a different story. You see a lot of people still doing a lot of the same work that they did before, not changing. And, the story of this is nutrition kind of happens across the state in varying different ways. Next slide. On the other side of the obesity epidemic, we have physical activity, and this one is much more variability. And a lot of agencies say that nutrition, because it's ingrained, is, it's part of WIC, it's part of all the other smaller services. Physical activity is much harder and it's much more grant funded. So you see a lot more transition within those services from what was done in 2010 to what is done now in 2012. Next slide. So prevention and population health promotion is our most disparate service if you look at max and min number of staff and FTE. Oh, and I'm sorry, I meant to say it, I meant to change this, I'm so sorry. So personnel and FTE on this table are actually swapped accidentally, so which makes sense because you're like, really, how can you have more FTE than you do personnel? So anyway, if you look at the max and min, you see a lot of our agencies just don't really dedicate much to, or any staffing to prevention and population health promotion. They focus on what is legislated to be done or what they absolutely must do to keep their doors open. And this seems as though it is a service that is just, it's kind of an added benefit. If you are able to and you have the funding to, you should do it, but otherwise it's not necessarily an absolute necessity. And you see that in in that. And you also see that we have some agencies that have a large amount of staffing and the ability to really have just more programs and more things going on in their agency versus those with no staffing. But you also, in the median, you see some variability in that. So the funding, again, still not very diverse. We were a little more surprised how not diverse this core service was than what we were expecting, but again, a lot of state and county funding. And the total funding in this one, it is the largest of our core services with $32 million across the entire state. Next slide. So now I'm going to get into the overall, and this is where the interesting pieces I'm going to draw out come out. So overall FTE, we look at 2010, 2012. We had a decrease across almost every single one of our agencies in FTE between 2010 and 2012. We know the MAX agency is our largest public health agency, and they had a CPPW grant that actually ended during this time period. So a lot of their staffing loss was due to that CPPW grant going away. But this really was a trend across all of our agencies, minus, our smallest agencies who really just scrape by to keep their doors open in general. So the one thing that is really interesting with our overall FTE versus our FTE in core services, and this is something that comes to the question of the measurement aspect of getting people to think about measurement in a different way. So as I mentioned before, our agencies really struggled to really parse out their FTE and funding by core service. It's not a way they've thought before. It's not something that they've really thought about before. And it's not something they've had to report before. So when I went in and I looked at FTE overall, and then I added all of the FTE from all of the core services, I looked at it, and there were about 900 FTE across all the core services, and then 1,900 reported total FTE. So huge disparity and discrepancy in what they're reporting in their core services and then what they're reporting as an overall FTE. Now, we do know a little of that discrepancy is due to those agencies who just refuse to fill in the FTE portion, but it's not significant enough, or I say significance in the terms of it's not enough for us to say, okay, well, that makes up for 1,000 FTE across the state. It doesn't. It maybe makes up for possibly 300. But not enough to really say, okay, that means that they're really thinking about this, and we need to think about this. We don't need to think about what that means anymore. Really, all it tells us is that we really do need to think about and talk through how we measure FTE within our core services to ensure that we are accounting for all of the work of the local public health agency in a way that makes sense. And, maybe it is conversations that we need to have with our agencies about, well, what do those 1,000 FTE really, where are those people working? Are they not working in the core services? And if so, how do we capture that information? Next slide. So here you can see a breakup of our FTE by each of the core service areas. And you'll see in this one that, a large amount of them are in prevention, population health promotion. But and what we hope to do and what we will do in our analysis later is break this up by agency size, or jurisdiction size, I apologize, the population that they serve. Likely we'll see that this will change depending on the jurisdiction size of our agencies, or even if we think about based on FTE at the agency, that we may see, as we saw with prevention, population health promotion, that certain agencies have a lot of staff dedicated to that and certain agencies have none or very few. And when we look at the structural differences within our agencies, we'll see this maybe parse out a little bit more. Next slide. The interesting thing is that though we saw a decrease in staffing across the years, we did not see any really negligible change in funding overall. So this is overall funding. So if we were to also look at the funding by core service in comparison, we would likely see some differences, but very little changes in our funding overall. Next slide. we asked the question of our agencies to think about this from the subjectively of, I expect that my local public health agency's budget in the next year will be. And what we're taking from this is that there's some optimism, more optimism in 2012 than 2010, in the sense of, I guess maybe optimism is not the right word. There is less pessimism in our agencies than there was in 2012 than there were in 2010, in that a lot fewer people are saying that they're having less funding for their next fiscal year than in 2010, which isn't surprising given the fiscal climate then and now. But the other interesting aspect that we're not seeing really many agencies who are thinking that their budget's going to be a whole lot bigger or greater than the previous years. So next slide. This is our overall source of funding. So when we look across all of our core services, again, we're seeing the large majority of our funding from the state and county. But when we look at it overall, it does diversify a little. And the services I showed you thus far really only show a small picture of all the core services. But still, it still is concerning to a lot of our agencies that we aren't diversifying a little bit more. Next slide. So when we look at spending across our core services, again, this mimics our FTE, but gives us a little peek into what we are looking at funding-wise and where there are service areas with less funding and more funding within our core services. So in summary, there's a lot more to come. We have a lot more service delivery data to be analyzed. We have a lot more data in each of the core services to be analyzed. So these questions that I have underneath it, I knew this was the slide where I was like, oh shoot, I meant to change the questions. The questions underneath here were what we were posing to our practice partners yesterday to think about how we interpret our data and what else they would like to see from our data. So if you want to answer these questions, you sure are more welcome to, but you don't have to. This isn't necessarily meant for this presentation. So the next slide is just if you have questions for us. That concludes.
Fantastic. This is really great work, and obviously right at the heart of some very important policy questions and research questions. So, questions for Sarah about what's happening to date.
I'd like to remind. Sorry, I just want to remind everyone if they don't have audio, they can always use the chat box for questions. Go ahead.
Yes, thank you. So I'll just to take moderator's privilege, just thinking very practically from a methodological standpoint. Do you have some sense about the nature of the difficulties that some of your agencies might have had in reporting the funding and staffing data elements for these activities? What kind of challenges they were facing in that regard? This is obviously an issue that we face in a lot of related studies that we're doing through the PBRNs and in PHSSR. So any insight into what kind of barriers that agencies are facing in reporting FTE and staffing in these service domains, and thoughts about some solutions that you might want to share?
So, that's a great question, Glenn. And actually, so when we presented this with our practitioners yesterday, it was the very first thing that was talked about and discussed quite at length. And the issues that they have is that, in the smaller agencies, for instance, when they think about FTE, they're like, okay, I've got 5 staff, and I am counting fingers, and, I can think that this person does 20 hours a week in this. And so when it comes to it, they are really counting fingers and half fingers, and the precision and the standardization of that is not there. So they struggle to define that. And one of the other things that we heard very clearly yesterday is that public health is not siloed in this way necessarily, that a lot of the communicable disease work that we define as communicable disease in the core service rule actually can very much meld into environmental health, or there are pieces of administration and governance that really can go across all of the core services. So how and when is an administration person administration and governance, and how and when are they communicable disease administration? And so one of the issues that we discussed at length yesterday was that standardization and that definition of where and how to define where funding falls into and where FTE falls into. And we, within the instrument itself, defined it in a way that we thought would help. However, it wasn't enough, and it wasn't to the detail that I think our agencies and our directors would like to see to really be able to understand where and how they put that funding in FTE. And, interestingly, yesterday, I will say we had one director who brought up this question and was just like, I just don't even think it's possible. And another director from the back, I wish I, had thought enough to, place them there, and I didn't. It just worked really well, who said, I know it's hard, but we had better start doing this, or we're not going to have a seat at the table when we need to have a seat at the table when it comes to getting more funding and getting funding from ACA and things like that. So it was great to see that kind of back and forth within our directors and seeing them fully understanding the practice implications of getting to that understanding and knowing why it's important to get to those definitions. Does that answer your question?
Yeah, Sarah, that's great. That's really helpful. I see we've got a question from Charles Brown in Connecticut. Can you see that one, Sarah?
Yes, I can.
Okay. You want to try to tackle that one?
Yeah. Is there anything that you would suggest to use from your work that could lay the groundwork for another state taking this on? Yes. Actually, and I know Lisa Van Rijmdonk, executive director, would be another person to tap the brain about this. I think some of the things that we have as far as thinking about, the detail within each of the core services. So, we have a lot of detail within our measurement that would give you an idea of does it make sense to put this kind of detail in our legislation, or does it make sense to make it more broad or what have you? And then one of the things that we also are struggling with and things that we thought about with these measures that we're using is looking at the, what is the, carrot and stick within the actual implementation of the core services, and how do we come up with measures that actually measure those core services in a reliable and valid way to know that we are actually holding our agencies accountable to that rule. So one thing I would say from our work is that, once we go through our reliability and validity analysis, is really getting at those reliable and valid measures that can look at how these, the implementation of the core services and how they're working. So that's one area. I also say that you could have many conversations with us about a lot of the other aspects of putting this into the core services into rule that maybe this project, but maybe not this project, but other projects that would really educate about putting that into rule in the future. I hope that helps.
Sarah?
Yeah.
So this is Julie, and I'm not sure this came up in the presentation, but one of the ways this has been administered in the follow-up is the local health departments. This is part of their annual report to the state health department, and so they've been. That's another reason, along with the pilot, that they've been invested in trying to come up with, help come up with the measures that are meaningful, and it's also allowing a way to get these integrated into practice.
Oh, that's a great point.
This is Scott Frank from Ohio, and I would reiterate the importance of that point. We were just talking in a meeting the other day about the need to reevaluate what reporting information we're going to anticipate from local health departments in Ohio. We have an annual financial report that we've had since the 1990s, and we use it in our work from 2005 on But ODH has expressed a willingness to relook at what information they ask. We also have a local performance standard questionnaire that we use, and ODH has expressed a willingness to look at both of those instruments and see how they could change to help us understand better what is actually going on in the local health departments. I would also say that we were just meeting with our DAX group yesterday and talking about core services and the way that we've done that in Ohio and how to anticipate which core services we're going to be looking at with our DAX program. And hearing your presentation really helps crystallize a lot of the discussion we had and thinking we're doing. So thank you very much for sharing it with us.
Absolutely. We can't wait to hear from you next week then, because we also have started this conversation just today. So.
Yeah, I think we're all looking forward to it.
Yeah.
Great. Other questions for Sarah and the Colorado team? I can't resist one more, Sarah. In thinking about the work you've done to date and in documenting, resources invested in these core services, are there thoughts about moving to a payment model, funding model that more formally recognizes and funds based on these core services, or is the funding model still more categorical or just disaggregated in terms of how funds are allocated especially from the state to the locals for these core services?
So there is one small, in the realm of all of the funding, it's only $8.8 million that our Office of Local Liaison, which we call Office of Planning and Partnerships here, actually gives out to our local public health agencies. In the past, it was solely based on population. They've reworked the funding formula to include core services as part of it. The issue that, and so therefore there are tiers within that include both population and include the core service delivery. What hasn't been determined and what we're hoping this project actually educates and helps is, how to actually measure which of the core services is done to determine which tier the public health departments are actually within. So that is an aspect, but that how those two kind of marry together is still kind of up in the air and yet to be determined. And we're hoping that looking at reliable and valid measures that we have within this project will start to help determine and really parse out where within the funding formula that kind of falls out. Now, again, it's still a very small amount of funding in comparison. So the carrot is like a baby carrot, but it's still, or I guess the stick is a baby stick, however you want to put it. But it's still there, and it's still something that is part of it, for sure.
Sarah, isn't there also, it seems like Lisa has talked about, there's also a committee that's working on what some of the billable services are that haven't traditionally been billable services?
So that's actually, so it's kind of a separate project, but it's one that one of our local public health agency directors said, just offhanded, had a conversation with Lisa that was like, we are going to go through all of our services and determine which ones are currently billable, which ones could be billable if we just changed them just a little. If we just said, if we actually had a different provider doing this service, we could actually make it billable. And which ones that we could see with implementation of the Affordable Care Act will then be billable, or we could have discussions about being billable. And so when he mentioned that to Lisa, Lisa's like, we need to start thinking about this across the whole state. So we have several of our agencies who are coming together and putting funding together to actually, we're contracting some of the work out to a consultant who has done a lot of work and knows the billing system in Colorado really well to know what is billable and what needs to change, et cetera. But this project and the measures we've gotten from this project actually gives us a lot of data about what our agencies are currently doing across what could be billable and what is billable, and will give us kind of that understanding of where this funding could then be in the future. So yes, thank you, Julie, for bringing that up. It's another thing that we're adding to using this data to be able to do.
Fantastic. Well, thank you again so much, Sarah, for sharing this work with us. I know that that there's a lot of interest, and you'll probably get to have a lot of follow-up questions and conversations as there's a growing body of research that we're doing through the PBRN program and elsewhere that are touching on these issues. And I think we can all learn a lot from the work that you've got underway there in Colorado. Thank you so much again for doing this on a fairly rapid cycle basis too.
Well, we appreciated the opportunity, so thank you all very much.
Fantastic. Other items are on our agenda. We did put a spot here to spend a little time debriefing with some of our colleagues who were part of the Academy Health Scholarship, Academy Health Meeting Scholarship program this past summer. This was a really neat opportunity that was teed up by our friends at Academy Health to get some of our PBRN leaders and colleagues more engaged in the Academy Health research meeting, not just the interest group meeting, but the larger research meeting as well, to stimulate more discussion and dialogue and hopefully down the road collaboration between our work in PHSSR with the PBRNs and the larger health services research and health policy research community. So I think we have a couple, and you see from this slide, these were our Academy Health PBRN scholars that successfully competed for this opportunity this past summer. It was great to see everybody there. We had a chance to at least have lunch together, I think one of the early days of the first day of the meeting. And I know that our scholars went in a number of different directions to draw some connections between their work and some of the other work that's happening in the larger field. And we wanted to take a little bit of time just to hear back from some of our scholars, some of their reflections from what they learned, what they saw, in particular maybe some insights into possible areas of synergy and points of connection between the work that we're doing here with our PBRNs in PHSR and what's happening in the larger research and policy environment. So I'm not sure who's with us, who's teed up. I know I did hear Scott and Sarah, obviously, and Julie are on the line. Whoever wants to jump in and have some comments or insight to share, please go right ahead.
Glenn, this is Lisette. I'm going to start with Marion Allred. She was not available to be on the call, but she did send me some notes that she wanted to touch base with. She said the most useful session for her was the breakout session A, which was the community health improvement during the Public Health Systems Research Interest Group. She felt that it would be essential for other PBRNs as we look at how local health departments can apply best practice and practice-based research with limited resources. The QI process and CHIP process being driven by national accreditation is a great opportunity, and she found it very exciting to learn more about that. Additionally, she felt that the sessions helped her make many connections that she would find valuable since the annual research meeting, and inspired her to consider pursuing a doctoral degree in future to further explore this research. So that's wonderful.
Fantastic. Thank you. Thank you for that. And it was great to have Marion a part of this. It was I had not had the pleasure of meeting her yet. I know many of our colleagues in North Carolina, but I was actually able to meet her in person at the meeting, and I know she's a great addition to the PBRN team down in North Carolina.
Well, do we just want to go in order on this list? I'm happy to go next.
That sounds great.
This is Scott from Ohio Rampy. And this is the first time I've been to an Academy Health meeting. I loved the meeting. I thought it was great, though I will say that one of my most important reflections from it is that If we talk about the health system spending about 95% on medical care and 5% on public health or less, it felt a little bit like that at this meeting too, that about 95% of the meeting was oriented towards medicine and about 5% oriented towards public health. Maybe a little underestimate, but I don't find that troubling. I take that as a challenge and believe that it's up to us to really demonstrate the need and value for the public health systems and services research to take a more prominent role. And clearly the interest group is going about the business of doing that. I've restricted, we were asked to sort of comment on a couple of sessions, one that particularly interested us and the others that would help other PBRNs. And I've restricted myself away from the interest group meeting because everything in that meeting was useful. But there were two sessions that I particularly found valuable, many that I found valuable, but the two that I'll comment on. One was a presentation by Carol Simon, who is a Senior Vice President for the United Health Group for Health Reform and Modernization. And the presentation focused on geographic variation in cost, quality, and population health, using primarily hospital-based data, but also looking at enablers of healthcare efficiency, and I think probably the most important message coming from this for PBRNs really is the value of GIS mapping and using or portraying our findings, taking advantage of mapping systems. They presented a variety of pieces of information on a national level where they really had great maps describing different variations in these issues. And I would love to see a formal effort to within the group to maximize the value of such mapping. The other session I'll comment on was really an interesting one to me, and it has followed me home in terms of thinking about other possible research, but it involved the community health benefit requirement for hospitals. It was a session in which we had a great overview about the community health benefit by a woman from George Washington University. And then one presentation that was somewhat community-based on the community health benefit. Well, one that was, let me put it this way, one presentation that for me was a demonstration of how not to do the community health benefit, and the other that was a presentation on an effective use of that community health benefit in partnership between public health and hospitals. So that contrast, which wasn't intended, but that contrast between one that seemed particularly bad, which involved getting the money from a hospital and then sitting down in a room with one person for 6 months and working on that, where the other really represented true partnership between the local health departments and the hospitals in that area. So it continued to stay with me as something that is worth further investigation, particularly because collaboration in our county here in Cuyahoga County between hospitals and public health around community assessment through the community health benefit has not gone well. So those are the two sessions that were most interesting to me, and I look forward to future involvement with these meetings.
Great, thank you, Scott. Why don't we'll go ahead down the list and then see if we've got questions or comments from anyone else. Is Michelle with us as well? Michelle, do you have some comments to add?
Yes, hi Glenn, I'm here. So this is Michelle, also from the Ohio PBRN network. It was as well my first time attending, and it was really overwhelming to see all the amount of topics that were covered throughout the various days. And I tended to stick more to the public health sessions which they had outlined. But I also found the PHSR interest group meeting particularly helpful, and just since a lot of the names were familiar and the projects were very directly relevant. Two presentations that really stuck out to me. One, which was in the interest group meeting. I think the information had been disseminated to the group before, but it was 10 tips for improving the field of PHSSR by Randy Boberg from the Urban Institute. I personally just found it really affirmational that someone's done an evaluation of the field, and commenting about how it is young, but that they do have suggestions based on the work that they've done, talking to the different local health departments. And I think during during the PBRN grantee meeting in Keeneland this year, one of at least the small breakout groups, we discussed very heavily funding sustainability. And I know that's something that we talk about here as, with our network, we've really only been funded by Robert Wood Johnson Foundation, but we've been talking, we have these great projects and are hoping to, maybe even partner with our State Department of Health in order to potentially find other venues to fund these projects, which are really relevant. And so, I think overall he was a really engaging speaker, and just really talked to, helping how to really further this field. So that was something that, I think was really beneficial for our PBRN network, specifically because he commented on, that it's such a great network, and how to expand it. On the other side, for my personal interest, one of the most compelling topics or presentations I attended was actually a policy roundtable, and it was on nudging food choices, so New York City's experience during the Bloomberg era. They had a variety of different speakers. A representative from the New York City Department of Health talked about their approach and how they're trying to increase access to healthy foods and decrease the consumption. They also involved a discussion on, the research and evaluation, obviously, with how obesity is such a problem, but then really dug down into the legal issues, as well as the, political feasibility of actually going through something as grand as what they're trying to accomplish. And it also hit home because during that time they discussed how Cleveland was in the middle of their trans fat ban, and how it was even able, despite the Senate trying to amend the state budget to prohibit the different municipalities from regulating the ingredients, that with eventually a Cuyahoga County judge sided with the city. So they commented on Cleveland, so that was pretty great to hear as someone from the area. So that was just something that really interested me, and just seeing how New York's really kind of setting the precedent and absorbing a lot of the legal costs, with the hope that there will be a trend towards similar adaptations across the country. So I'm really appreciative to Academy Health for the opportunity to attend, and I'm really looking forward to going and maybe even presenting some of our projects in the future.
Fantastic. Thank you, Michelle. How about Brittany? Brittany, are you with us from New York?
Yes, I am. I'm here from the New York PBRN. I also have some comments from Erica Martin, who I attended the Academy Health Conference with. She wasn't able to make the call, but did send over some stuff for me to discuss. And first off, I thought it was just really great, the idea of sending practitioner academic pairs to the conference. I hadn't considered inviting Erica or asking her to apply. I wouldn't have without the encouragement on the applications to do that. And it was just a really great opportunity to spend some time with her, since she's a relatively new member of our practice-based research network, coming from the field of health policy, and being able to attend and digest some of these meetings together. It was just a great time, and definitely really helped form our relationship as, practitioner and researchers, which I'm looking forward to on the upcoming DAX research project, which she'll be working on us with. But from Erica, she particularly enjoyed the session the first day, What a Long Way We've Come. It was Methods to Inform Policy and Practice, and it sort of discussed the ways in which computational methods have transformed our ability to study health issues and make evidence-based decisions. I attended the session with her, and I remember the presenter discussing about how, raise your hand if there are people in the rooms who did their PhDs on research on IBM punch cards, and how over the past several decades, our ability to just process information, analyze information has just, increased by leaps and bounds, and how important that is for practitioners who are in the field who may, have gotten an education decades ago to stay engaged with researchers who have all those cutting-edge methods and can apply those methods to the data that are being collected by public health agencies. And she was also attended several interesting sessions on mobile health applications. There are a lot of unanswered questions about which types of apps work best and under which circumstances PBRNs might want to explore collaboration with developers and academics in computer science and the involvement of mobile health and public health research. As for me, I had a great time at the conference. I definitely had brain drain for like a week afterwards. But one of my favorite sessions was on healthcare leadership and organizational learning and quality improvement and the role of healthcare leadership in that. And one of the great talks was by Sarah Singer from Harvard School of Public Health, who was doing research with the VA. And she was looking at organizational learning within and between VA centers to see what influenced organizational learning. Was there leadership there, processes and practices that encourage that kind of constant organizational improvement? And one of the interesting findings that I really thought was insightful, especially with public health, is that the service type within a VA hospital explained more of the variation in organizational appreciation of learning than between medical centers. So it wasn't just the location being in the same building together, but it was what specialty were they working in, with specialties like mental health being the most supportive of that constant organizational learning and improvement, where specialties like imaging and lab technology were least supportive of it. So perhaps reflective of the relative complexity of each specialty. But from a PBRN perspective, I thought it was interesting because it was definitely struck home with me when you just look at health departments as, entities in their entirety, and you look at them at a county level, county to county, when in fact if you were to stratify it, slice it a different way and look at environmental health across the state or communicable disease programs across the state, you might see a lot of different variation, particularly when it comes to being prepared for public health accreditation or adapting or planning ahead for ACA implementation and working with different, health agencies. So I thought that was really great. And one other comment that I had from a session on rapid cycle evaluation, which I have brought home and used in plenty of meetings, you must always consider the trade-off between data rigor and rigor mortis when it comes to making decisions and applying findings, not waiting until everything is perfect, but kind of moving on the fly and changing and evolving as you go.
Great, thank you, Brittany. That's very, very helpful. I was at the meeting the whole time. You guys went to different sessions I went to. This is great to hear this, hear the feedback and discussion. Sarah, you still with us?
I am. I got cut off for a minute, but can you still hear me?
Yes, absolutely. You want to give us any observations you have?
Yeah, so the two I had prepared, people have already talked about, so I feel a little remiss in talking again. The session about community health benefit that Scott talked about earlier was one that was particularly of interest to me, and I would definitely echo his sentiments about, it didn't seem purposeful, but it was very obvious the two different approaches to the community, to the Chinas that they actually presented about. But the part of the session that was also very interesting is one of the presenters, whose name I actually cannot remember right now, actually talked about what the legal requirements of community health benefits are within each state across the nation. So they had done a legal research to look at what those community health benefits requirements are, or what the legal ramification, or what the legal what the laws would say about community health benefits. And we've actually been in conversations with her about marrying our research that we've done on the legal requirements for community health assessments, community health improvement plans in health departments, and those community benefit laws, and looking at where there are synergies and perhaps some areas where they work against each other. So that was really of interest and something that's spurred some additional potential research that we've had conversations about. The other one that I went to that I wanted to talk about that's already been talked about was the organizational learning. The thing that I actually took from that one that I thought was really interesting was that this is, the area of HSR research that we are really diving into is, and I believe a lot of the PHSs are, which is that what infrastructure needs to be put in place to really deliver the services that a lot of people have done HSR research on. And what I took away from it as well was that there's a field in HSR within organizational learning that also feels a little bit like a redheaded stepchild. There are a lot of people in that session who commented and were like, this is where we need to be doing research and there's no funding in it and nobody cares. And it was just interesting, and it definitely harkened back to some of the things that we've heard ourselves. I will talk about one that I thought was really interesting, a methodology session that talked about qualitative comparative analysis, which is, we have a lot of qualitative data from our interviews and from our the work that I've already talked about today. And this actually, and I haven't tested it yet, but it's one that I've started doing some research on and thinking about doing some analysis of qualitative data that can actually be a little bit more quantitative in the way you present it back and makes the qualitative data very, very useful and very presentable back. So it was incredibly fascinating. The way she presented it was so, made so much sense and was just seemed so obvious, and a great methodology that I am doing more research on and would like to use a little bit more in some of the work that we do. So I would agree. I think the whole thing was incredible. It was my first Academy Health meeting, and I do hope to make it part of a regular or something that I could possibly do every other year, since it is a little more expensive. So greatly appreciate the scholarship opportunity.
This is Scott. I actually do have the name of the woman that I think we're both referring to, and Sarah, and that is Martha Somerville. And I said Georgetown or George Washington, but she's actually at the University of Maryland.
Yes.
And she did really a fantastic job of summarizing what the status of the rules are as they relate to the hospital benefit and how those are likely to change moving forward, and how those changes could be leveraged by public health to move towards real partnership. The comment that I made at the meeting, and one that I think resonated with a lot of people, is that the session really demonstrated what essentially represents a struggle for ownership of community health assessment. Are the hospitals going to own it moving forward because of this community benefit requirement? Is public health going to own it? Or can it be owned together rather than competing with each other? And we did see both presented.
And I was very happy in that session, Scott, when you stood up and said that, because I was thinking, I was like, you are taking the thoughts out of my brain. So, thank you.
Excellent. Thank you, Sarah and Scott, for those insights. Julie, do you want to add some of your perspective?
Well, just a little. So this is the second time I had been to Academy Health, and it really is it's a great meeting, and it allows kind of a lot of different perspectives coming together. Now, being in Breckenridge at our public health meetings and 24 hours till having to submit our Prevention Research Center proposal, I have to say I don't have my notes. One of the things that actually is
Condolences, Julie.
Thank you. Yeah, the same. I know there's a few others in that situation. But one of the things that has kind of made it into our proposal, our PRC proposal, it was a session, a methods-related session, which I can't remember the name of, and Lucy Savitz, who is Director of Research and Education at Intermountain Institute for Healthcare Delivery and Research in Utah, was one of the speakers in a session that was really about integrating practice into research, and her setting is much more in healthcare research, but that's something I've been very interested in how we really design things within the practice setting rather than having to always overlay research and measurement systems. So she will be part of our Applied Public Health Research and Practice Steering Committee for our Prevention Research Center to bring some of that expertise from healthcare to think more broadly about the public health and community setting. And I'd be happy to talk further with anyone who's really interested in this. How do we better integrate research and practice?
That's a great point, Julie. I had similar interest in thinking about how we can take some of the strategies that are being used in places like Lucy's place in Intermountain and figure out analogs for making that same kind of connection in public health. She's a great insight. We actually had her out to Kentucky last month to talk at our CTSA meeting about these issues. So
cool.
Wonderful. Well, that's great. Any other questions or comments that folks have, or folks on the call want to ask in follow-up?
Hi, Glenn. This is Anna. I'd like to just take a second amidst the road noise to thank all of the scholarship recipients for participating today, and to especially thank Kate Papa and Natalie Tallis, Lisa Simpson, and the whole team at Academy Health for making this possible. But there was one session that I attended that I think had relevance for the PBRNs in a very strange way, and that was a session on mentorship that was headed up by Shoshana Sofair. And it occurred to me, although it was primarily designed for an academic mentor-mentee relationship, it occurred to me that in our PBRN partnerships, in some way, everyone is a mentor, whether we're mentoring, whether you're a practitioner mentoring a researcher to help them better understand practice, or a researcher mentoring practitioners to help them better utilize the research, or to, as Julie was just talking about, mentor each other in finding ways of better integrating research and practice. And that session was just so helpful because it really talked a lot about being thoughtful in how you provide mentorship, in really listening and ensuring that while you're obviously pursuing your own goals, you're also really listening to your mentees' goals for the work that you're doing collaboratively. So I thought that was a really special session, and I just wanted to raise it. And again, thanks to everyone for being able to participate today.
This is Brittany. I just wanted to echo that. I attended that session as well, Anna, and it was fantastic. I really, really enjoyed the insights from people just talking about kind of being in a discipline that doesn't really have a home.
Wonderful comments. I know Kate Papa is with us too, and has posted a couple of comments on chat. Kate, do you want to say a few things while you're with us?
Hi, everyone. I was trying to stay quiet so people would feel welcome to be critical. So I just put a little chat in if there's any comments. This was our first year of doing this, so there's always little big and little ways that you can improve. So if anyone has any suggestions for us to improve the program, please send them my way. But congratulations to all the scholarship winners, and it's just so wonderful hearing how much you all got out of it. And I always make these gross perceptions about what sessions you're all going to, and I don't think any of the ones I thought you were going to were mentioned. So this is also really exciting for me to hear the different sessions that you went to and how much you learned. So thanks for inviting me today.
Well, thank you again, Kate, and thanks to all your colleagues at Academy Health for your strong partnership with us, and it's really important. And this is just one manifestation of that, as we're all moving toward better PHSSR.
Hey, this is Scott. If we've got Kate on the line, Kate, I've had trouble following up. We heard at the conference over and over that slides and presentations would be online and we could take a look at them, but I haven't been able to figure out how to do that. You don't need necessarily to explain it now, but if you could let me know through an email, I'd really appreciate it.
That's a great point. I was actually going to mention that too. Academy Health does a good job, and I believe if you just go back to the agenda, the online agenda for the 2013 meeting, you will magically find that now next to the speakers on the days, the sessions you're interested in, you'll find PDFs of their slides, at least for those speakers that complied and provided them. I'm pretty sure that's correct. Is that right, Kate?
Yes, that's correct. The interest group meeting slides will be always on our site for anyone. The ARM presentations are only on accessible for people who went to the annual meeting or Academy Health members. So I'll talk with Anna about getting information out to everyone to be able to access those.
Yeah, because those are the ones that I'm interested in. I mean, there are a number from the ARM meeting that I'm interested in accessing, and I am now a member, Kate, so I'll look forward to your communication about it. There are some things I really wanted to follow up on.
Well, thanks, and I appreciate your comment earlier about the 5%. So having more members like you means we can get up to 8% next year, maybe.
Thanks, Kate.
And if I could jump in while we've got Kate on the line, I'm not looking at an agenda, so this may be on there for later. I don't know, has Kate had a chance to talk a little bit about the translating PHSSR document that's now available online from Academy Health?
Sure, Anna. I can send the link. I'll send you a link afterwards to make sure everyone gets it. But we were trying to create a tool based on some discussions we had with folks at Keeneland about translating and disseminating your findings. So it's supposed to be sort of not scary. And some of the things in there you might already know. And I think one of the best things about this tool is actually the resources that we're sending you all to. But it's sort of about making sure you engage your research user from the beginning and developing your research questions with the researcher in mind, and then some sample suggestions for ways to disseminate and samples of those ways. So like press releases and op-eds and other ways you might wish to disseminate.
That's fantastic. Thank you so much, Kate. We'll make sure to put that we push that out to our full set of PBRN stakeholders. So that's a wonderful resource to have.
Can you hear me? This is Julie.
Yes. Hey, Julie.
So just a comment that brings up is that the format of, so there was a workshop for people who weren't there that was sponsored, tell me if I'm wrong, it was sponsored by Academy Health. Or am I in the wrong meeting? There was on dissemination. Anyway, we have used that format of questioning in a couple different groups, kind of altered it for slightly different purposes, like about scaling up research. So appreciated that. Maybe that was at Kentucky, I'm sorry.
Yeah, that sounds like the session that Academy Health led for us in Kentucky at Keeneland Conference.
Right, okay. So sorry, but it made me think of that.
Closely related, but yeah, absolutely. Yeah, and again, yeah, another great session that Academy Health put together for us.
And I believe that session was the genesis of some of the material that appears in the new publication.
That's right.
It was, Anna, thanks for all your review on that. We can also include the slides from that Keeneland session. I'll include them, Anna, when I send you the links to the things folks have asked for today, if anyone needs a refresher.
Excellent. That would be great. Thank you so much, Kate. And thanks to our scholars again for taking this time today to share with us your insights and observations. And hopefully others who haven't yet had the privilege to attend the Academy Health meetings have a sense of just the great opportunities that are there. So we do have a few more items to get through in our remaining time together. A couple of things to check in on more on the administrative side of the house. First, related to our consolidated center operations, I think we sent to most of you last month just an announcement letting you know about our effort that started officially this month to consolidate our two national coordinating centers that are based here at Kentucky, and particularly consolidate a number of our administrative operations. That officially kicked off again this month, where our National Coordinating Center for Public Health Services and Systems Research is kind of now formally integrated with our National Coordinating Center for the Public Health PBRN program. We're excited about this. This is allowing us to realize some greater synergy between the programs, some efficiencies as well in terms of consolidated center operations. And really, in terms of the programs and their operations, you really shouldn't see much difference. We hope you'll see hopefully some improvements in in some of our operations. But in terms of the PBRN program, that continues to be an important program, and it has its identity, and our core staff that's working with you on the PBRN program remains in place. So we wanted to just reconfirm that with you, that our moving to a consolidated structure is meant really solely to improve our ability to operate these programs and to offer support, technical assistance, coordination, and capacity building for you in the PBRN program. So that piece won't change, but we hope you'll find we're able to be a bit more effective and efficient in how we operate things. As we talked about in that email that went out last month, we moved to kind of a core structure, which is a little bit more of a traditional structure for a consolidated center operations. We have a extramural research core that houses and coordinates really all of the extramural research opportunities that we coordinate through the two programs. Obviously, our PBRN program, the extramural research opportunities that we create with the foundation for our PBRNs fits within that core, as well as other extramural research programs and CFPs and RFPs that we work with the foundation to coordinate. We've got a large and enhanced core devoted to stakeholder engagement and translation that is really we're placing enhanced emphasis on and capacity through this consolidation. And so I think hopefully what you'll see over the next few months is some exciting new developments around dissemination, translation, vehicles, as well as engagement opportunities in terms of engaging with our policy and practice and research stakeholders. So exciting things to come from this consolidated center, but please be reassured that the PBRN program as a national program of the foundation continues to operate and move forward, and our core staff, myself and Anna and Lizeth and our research assistants here and CB continue to be at your service and to be eager and willing colleagues on all of our PBRN related activities. In terms of dissemination opportunities, and Anna, I know you're on the road, so feel free to jump in on any of these you want to. I know that you've got road noise, so I won't put you on the spot, but just jump right in if you want to elaborate on any of our agenda items here. Frontiers and PHSR continues to roll along. Just a reminder, we're always eager to get new content, new papers, new emerging findings and preliminary findings from your research in Frontiers. We're also working some improvements in the Frontiers vehicle as well, and so we're always interested in getting your submissions. It's a great vehicle for, again, getting out some early findings quickly. One of your first publications from a project perhaps would be a great a great venue to use Frontiers for. It's got a number of features. It's optimized for social media, optimized for directing people to your work in online resources, Google Scholar and others. So a great vehicle to use. And you get great metrics. When you publish things there, you get great metrics on who's downloading, who's using your publication volume and the timing of access, which is really helpful. Keeneland Conference and our PBRN grantee meeting. Again, we've got planning underway for these two big efforts. We're continuing to improve on the process and moving to more of a stakeholder-driven process in planning for particularly the Keeneland Conference meeting. We're now in the process of we've appointed a planning committee and a leadership to with stakeholders across our enterprise to help with that process. Just wanted to make sure you knew that was underway. And as you have ideas that might be relevant for the 2014 Keeneland Conference and/or the PBRN grantee meeting that we hold in conjunction with that conference, don't hesitate to let us know, and we can feed that information to our planning committee members. And thanks to those of you who are serving on that planning committee. We appreciate your continued help with that important set of activities. We also have a website redesign underway now. One of the manifestations of our consolidated center operations this month. We're going to committed to continuous improvements in using the web as a vehicle for getting your work out. As a part of that, the new website design is planned to be much more content-driven. We're really going to attempt to maximize the content from your great work in the PBRN programs and research programs, as well as other research projects and products, translation products and tools that come out of your work. So as those are completed, obviously make sure you give them to the foundation and submit them through the foundation's product submission process. But make sure to get them to us too, and we can give them life on the website and steer even more users to your great work.
And remember, if your products have a permanent home on the web, they become reportable products for the foundation for your grant. So by all means, please share with us items you would like. Each PBRN is going to have its own dedicated single page that will link out to any products you provide us with. And this is sort of a side item, but if you could send us a picture from your PBRN, that would help make the pages look nicer. But primarily, we want to get those products up there so that both people can access them who need them, and you then have a home to call things products. So thanks.
Great. Wonderful points. And thanks to Anna in particular for her leadership on that redesign. We're really excited about it. Also on the dissemination front, APHA is coming up at the end of next month. Really, they kick off some great things happening at the APHA meeting. As always, we would please ask that you let us know as you have PBRN related presentations that will be happening there. Let us know when those will be. Send us information about that so we can put that into our compendium and help you get the word out about that great work. We'll be in the home of our Massachusetts PBRN, and so looking forward to connecting with those groups. We will be scheduling some sort of a social connection, as we usually do in conjunction with the APHA meeting for our PBRN friends, and so stay tuned to that. We'll pick a night that looks good and try to get together for some informal conversation and connections as we get close to the meeting. We'll share details on that, but we're we're excited as always about APHA coming up. Funding opportunities. There's always a number of opportunities to think about. Again, just a reminder for the PBRN program in particular, we are open for business for receiving quick strike research applications, and hopefully you've gotten notices about how to do that. If not, let us know. We are reviewing these in batches. We get our first batch closed at the end of last month, so for those of you who submitted your quick strike application in the August batch, you'll be hearing back from us very shortly. And again, if you've got an idea, you can submit those at any time, and just follow our fairly simple, straightforward application instructions. It's meant to be a streamlined application, and let us know if you need more details or need help on that front. But we are certainly open for business in terms of quick strike applications. The Foundation's Mentored Research Scientist and PSSR opportunity closed last month, and applications are in hand and going through the review process now. So for those of you who have who've got an application in for that, stay tuned as that works through the review process, and notifications will follow on the timeline associated with that funding opportunity. We've talked about some other related CDC opportunities. The PRC applications, I think, as we heard, are going in today or tomorrow. We know we have a number of several PBRNs who are connected into work of the prevention research centers, and excited about what these new applications, this new cycle of funding might create in terms of opportunities for collaboration between PRCs and PBRNs. The other big CDC center grid application that's out is the Injury Control Research Center applications. Those applications are due, I think, later in November. And again, just a reminder, if you've got a injury research center in your neighborhood, in your neck of the woods, you may want to, this would be a good time to connect in with that group and perhaps find a role for the PBRN within the next cycle of funding for the CDC-funded injury research centers. As we've talked about, there's a lot of interest at CDC in closer engagement and collaboration with our PBRN program in particular around injury-focused and violence-focused public health services and systems research. In fact, Ann and I just earlier this week did a webinar for the CDC-funded states that are funded through the Core Violence and Injury Prevention Program grant. And I think so we were connecting directly with colleagues in state health departments who are on the practice side of implementing CDC-funded programs, and I think our feedback from that call is also a lot of enthusiasm for engaging in practice-based research. So keep that on your radar, and think about reaching out to your colleagues in your state health department who might be doing injury violence prevention, and if you have an injury research center in your neighborhood, reaching out to those stakeholders as well. Also, just wanted to say just a quick thing about accreditation-related research. In part, they just came back from a meeting of the Public Health Accreditation Board and their newly reconstituted Research Advisory Council, which I've been invited to serve on along with some of our other PBRN colleagues. Betty Beckmeyer from the Washington Network. Who else? Paul Irwin from the Tennessee PBRN Network are on that. Les Beich, who has some connections into the Florida PBRN. And just a reminder that this is obviously there's a number of important research issues that surface around accreditation that to be thinking about in the PBRN program, and also the accreditation program, the national accreditation program. Remember, is a potentially powerful translation vehicle for your research. If your research is identifying important, effective practices, administrative practices, strategies related to staffing, to financing, to service delivery, to core functions, One way that research, one vehicle for translating that research might be in using that research to help inform the development, the refinement of new accreditation standards and measures in this program. So don't forget about that. Be thinking about that. And in particular, I want to serve as a vehicle for helping to translate PBRN research into the accreditation environment. We've funded a number of accreditation relevant research projects through the PBRN program over the last couple of years. Some looking specifically at issues around preparing for accreditation. I know in Nebraska and Missouri and some other states. Other states that have been looking at issues around practice variation around some of the prerequisites for accreditation, like the CHAs and CHIPs, and the Wisconsin PBRN study looking at the quality of CHA and CHIP processes, or our Connecticut PBRN, Kansas PBRN study looking at the comparative study looking at different approaches to CHA and CHIP, regional versus single county approaches. As these kinds of PBRN projects start to bear fruit, a great translation opportunity exists with getting your findings in, connected in, sharing them first and foremost with our stakeholders at FAB, and then thinking about how your research might inform what accreditation requirements, accreditation measures, standards, et cetera, might motivate new directions in accreditation through that program. Let us know if you've got ideas. Let me know if I can take your research with me to meetings at FAB and the Research Council. And be thinking about new avenues of inquiry that you might want to undertake through your network that are relevant to accreditation and the related quality improvement efforts in public health. So just a pitch on that. Congratulations to Natalie. We wanted to congratulate her for being named as one of the White House champions for change in public health. This is really a remarkable distinction, and wanted to make sure that everybody saw this. Natalie, our colleague, great colleague and friend in the New Jersey Public Health PBRN. I don't know if she's with us at the moment. She is, I think so. It looks like she is. But again, congratulations on that. I don't know if you want to say a word or two about your experience at this stage.
Glenn, I would like to read just something from the White House website, just a short little paragraph about what exactly Natalie was involved with. So last week, the White House highlighted the importance of prevention in public health, recognizing local leaders, also known as champions of change, from across the country. 8 champions of change share their incredible work, which in many cases are supported through the Prevention in Public Health, an important component of the Affordable Care Act. These 8 champions were selected from over 900 nominations, higher than any other champions event, and a testament to the important work in prevention and public health happening across the country. They talked about how through encouraging preventative screenings, reducing health disparities, promoting physical activity and healthy eating, and fighting health care-acquired infections, public health and prevention efforts are building healthier communities for all Americans. So it's a wonderful, wonderful
yeah, it's amazing that we have an awardee in our PBRN family. So again, congrats to Natalie, and we'll look forward to hearing more about her experience with that initiative. It's obviously a great honor for the work that she's doing in public health for the great state of New Jersey and beyond. So, reminders, upcoming meetings. Next month, our monthly PBRN meeting will be October 17th. And actually, we'll be hearing from our colleagues in New Jersey. New Jersey PBRN will be up for the Research in Progress presentation. Some exciting work happening up there. We talked about already some of our 11 DACs grantees that are part of the PBRN Delivering Cost Studies. We're looking forward to hosting you next week, coming in on Thursday night for dinner and being at our workshop on Friday to collaborate around the refine the designs and implementation studies, processes around the delivering cost studies. Really excited about this. A great set of studies that are teed up and underway now that we're going to learn a lot about cost estimation, cost variation, and its policy and practice implications through these great studies. So we'll see you next week for those of you involved in DAX, at least a representative from your team. APHA meeting. Oh yeah.
Sorry, Glenn. I have one more agenda item before the APHA meeting. Did not make it on this slide, but our quarterly training is actually scheduled for next Wednesday, September the 25th, from 1 to 2 o'clock, and we will have the Public Health Foundation train data set. So it'll be very interesting. We're going to do a live demonstration on how to use that directly from the website. So I will send out a calling information probably tomorrow sometime, so please be on the lookout for that. But it's Wednesday, September 25th from 1 to 2.
Great. Yeah, thank you, Lizette, for reminding us that was on the printed agenda and just not on the slide here. That is a potentially powerful resource, underutilized data resource at this stage, but offers some potentially powerful insight into, again, training uptake, exposure to workforce training, looking at some interesting possibilities for looking at geographic variation. I had worked with chaired a dissertation committee for a student back in Arkansas who used this for his PhD dissertation, and this data resource and found it to be very, very productive, again, for exploiting variation and exposure to training and workforce development. And again, the APHA meeting coming up on the 2nd through the 6th of November, back in Boston. Look forward to seeing many of you at that session. So we've got a few more minutes. If there's anything else, any other questions or comments that people want to put on the floor for the good of the order before we close out today's meeting. Well, hearing none, we can end a little bit early. We can give you back 10 minutes. Thanks again to everybody for being with us. Thanks to Sarah and our colleagues at Colorado for hosting our Research in Progress section. Thanks to our Academy Health people and scholars for sharing your insights with us. Thanks to Kate Papa, as always, for the great work you're doing with us at Academy Health. And we will see all of you back here next month, same bat time and bat channel. If not before, if we don't see you before in any of our other connection points along the way. Let us know if we can be helpful. Give us a call, send us an email, stay in touch, and we'll look forward to seeing you soon. So long, everybody.